Hi and welcome. My name is Leda McDaniel. I'm a physical therapist and adjunct professor at Emory University in Atlanta, Georgia. Today, I want to talk about the differences between osteoarthritis and rheumatoid arthritis, and specifically the relevance to physical therapy practice. So, a brief overview of the pathophysiology, differentiating features from a medical context, but then putting it back into a physical therapy context and how we might be screening these individual patients, helping with diagnosis and referral to rheumatology, perhaps, and prescribing evidence-based treatment and education for our patients with these conditions. So, what are the differences between osteoarthritis and rheumatoid arthritis? What I'd like you to do throughout this lecture is try to keep those in mind. And if you would like to, engage with this lecture in some participation. I think it will help with the learning process. I find that myself. Just take out a piece of paper and do me a favor, draw a line down the middle and start two different columns to start to conceptualize some of the things that these two diseases or disorders maybe have in common, which is quite a bit. So we know they both affect joints and musculoskeletal issues that patients will come in with, and pain complaints at joints. We're often tasked with differentiating or trying to distinguish what is the cause of that pain. Maybe they have joint stiffness. What are the causes of stiffness? How long does it last? Do they have range of motion limitations, strength limitations? Some of those things and some of those questions, in addition to some of your systemic questioning and perhaps testing, will start to help, I think, help you see the similarities between these two pathologies, but also then we want to come up with the differences, both from a diagnostic standpoint, and once we understand a little bit more about the pathophysiology, we can better prescribe and help educate patients on the different treatment options or recommended treatments that they may have for these disorders. So keep that in mind. We'll talk a lot about the differences as we go through. Just as a jumping off point, want to present some data on how common these different disorders are. And we know as osteoarthritis is quite common and much more common than rheumatoid arthritis. So these are just a few statistics, about 5 years old, a little bit older, suggesting that within the US, adults, an incidence of osteoarthritis in one sample was around 10%, a little under 10%. And then rheumatoid arthritis was about 4%. As I mentioned, osteoarthritis is quite a common health condition, and a significant percentage of adults and proportion of adults will suffer from this, especially later in life. So it's a leading cause of disability in older adults. And what we'll see is that increasing age is the number one risk factor for developing osteoarthritis. So that's quite significant. So within your older patients, this should always be front of mind as a potential contributor to joint pain or joint dysfunction. And there's a high estimated lifetime risk. So as high as around 14% could suffer from osteoarthritis. Starting to think about the differences between these two disorders. In rheumatoid arthritis, we're thinking about more of a autoimmune disease and inflammatory condition that has systemic effects. So this is going to drive some of the presentation. So many joints are likely affected in rheumatoid arthritis versus osteoarthritis is more of a localized joint destruction and inflammatory process. And so what we often see with osteoarthritis, though not always the case, is that fewer joints are affected. It could be unilateral. It could be just one or two joints, versus rheumatoid arthritis is common multiple joints and multiple small joints. So joints of the fingers and hands are very common in rheumatoid arthritis, and specifically in the metacarpal phalangeal joints or MCP joints. It's a common place that rheumatoid arthritis affects some of the joints in the fingers and the hands, versus osteoarthritis can affect joints in the fingers, but it's more common in those distal digital joints, so DIPs, PIPs, so distal interphalangeal or proximal interphalangeal joints. And then within osteoarthritis, probably the two most common, I will say the two most common joints that are affected by far overall, the knee joint is affected most often as osteoarthritis, and then the hip. But there are other joints that can be affected. In osteoarthritis, what we see is those weight-bearing joints take the brunt of usually this pathology. Some other things to keep in mind, and these are not necessarily things that you'll be performing as physical therapists, but this helps provide context for your history and medical review if you have access to these, and these can be some tests that patients come in with or potentially that you're informing them about and referring to other providers to obtain. So in rheumatoid arthritis, part of the diagnosis is usually the presence of these what are called auto antibodies, or antibodies that are attacking within the context of this autoimmune disease our own immune system. So individuals will likely have one, if not more, of these autoantibodies. So rheumatoid factor, rheumatic factor, Rh antibody, anti-nuclear antibodies, and anti-citrulline or anti-citrulline antibodies. Furthermore, they're likely going to come in with elevated markers of systemic inflammation, such as C-reactive protein, or an elevated erythrocyte sedimentation rate, which are markers of systemic inflammation. Versus osteoarthritis, not systemic. So you're going to have negative and not an autoimmune disease. So negative antibody tests are key, and those markers of systemic inflammation are not there. X-ray MRI findings, again, patients may have this, they may not. Upon X-ray or MRI, rheumatoid arthritis, you could show nodules at the joint and swelling. Joint deformities come later in the pathophysiology of the disease. For osteoarthritis, there are multiple scales that will rate progression or severity of osteoarthritis, such as the Kellgren-Lawrence scale. Won't present information on that in this discussion. It's kind of beyond the scope, but if you are interested, that is something I would recommend you checking out if you're interested in more about the imaging findings within osteoarthritis. In addition, the key trifecta that is usually present in osteoarthritis that is suggestive of joint damage is joint space narrowing, osteophytes or bone spur formation at the joint, and sclerosis, or an increased formation of bone at those joint surfaces because of the increased force at the bone surface or interface. Also, these nodes could be present at DIP or POP joints, referred to as Bouchard's or Heberden's nodes, and those are indicative or part of the sequelae of some of that osteophyte formation. We'll see that in a little bit. Okay, so here's your first test based on some of those signs and symptoms, some of those features at the joint. And what I want you to do is take a look at this imaging. This is a radiograph, and kind of jot down what you see. So the arrow points to the joint of interest. Think about what joint it is. Think about what you're seeing at those joint surfaces and interface, and then start coming up with rationale for which disease you think is present. Again, we're not asking you to diagnose these things as physical therapists. However, it's nice to start learning and becoming more familiar with some of these imaging presentations. So take a second and see what you think. And then here's kind of the key, or kind of the findings. This comes from an image of an individual with osteoarthritis, and it's osteoarthritis at the distal interphalangeal joint, remembering that OA preferentially affects the DIPs and PIPs, so that could be a clue for you. What we see is the decreased joint space and osteophytes, some of that joint degradation consistent with OA. Second imaging example, again, this is a radiograph, and the arrows are pointing to some of the joints affected. So take a second, try to think through what are you seeing in each of those joints, maybe the hand as a whole, and which pathology do you think is present and why. So for this particular image, this is an individual with diagnosed rheumatoid arthritis. You will see some similar joint dysfunction or features. So yes, joint destruction, causing decreased joint space and osteophytes. However, some of the differentiating factors that I want to key you in on are these joints that we're referring to here in the image are the MCP joints. Again, in rheumatoid arthritis, those are preferentially affected versus the DIPs and PIPs. It's more likely. You can also see some early ulnar drift, which is a joint deformity commonly associated with rheumatoid arthritis because of the degradation and loss of structural support of the ligaments and surrounding tissues at those joints. Brief review of rheumatoid arthritis, key signs and symptoms. So demographically, rheumatoid arthritis is more common in females. It's more common in those over the age of 65, and smoking is a risk factor for the development of rheumatoid arthritis, in addition to genetic factors that could contribute to the prevalence of the disease. It's characterized by a gradual or insidious onset, and flare-ups and remissions are quite common, with inflammation kind of spiking and then individuals having periods of remission. As I mentioned prior, this usually affects smaller joints and multiple joints, and there can be deformities later on. The keys to this diagnosis, or that are very characteristic of this disease, is that these individuals will have systemic findings. So increase in those autoantibodies and global inflammation. Because of that, they can also have complications in other body systems. So fatigue is not uncommon. These individuals also later in the stage of disease or early on, but as the disease progresses, can have symptoms and issues with other body systems, for example, cardiopulmonary complications. The treatments I'm going to get into a little bit later, but first-line treatments for RA, we think we really want these individuals to protect the joints to try to maintain normal joint function and prevent some of that joint destruction. So that could be splinting, bracing, patient education on positioning, but also first-line treatment. It's very important these individuals are on some sort of medication, and usually that takes the form of an autoimmune type drug, and DMARDs is just an acronym for disease modifying antirheumatic agents. So methotrexate is an example of this, which is an antimetabolite, and it's immune system suppressant. So we're trying to suppress the autoimmune component of the disease to control it, to help control it. Because we're not going to cure it. It's chronic progressive. So what's going on with the joint in rheumatoid arthritis? It's complicated, but this will give you a little bit of a pictorial idea of some of the inflammatory processes that are going on. So what we think is that local inflammation is driven by some of these autoantibodies, pro-inflammatory cytokines such as tumor necrosis factor, TNF, or interleukin-6, but many others. Those are just examples. And then there is this influx of inflammatory cells that contribute to the degradation and inflammation of the joint components, such as the synovium and joint surfaces. So we know that there's cartilage and bone destruction as well within the pathology of this disease process. There's usually a proliferation of synovial cells, but those synovial cells are altered. So they're abnormal cells, and they're often termed fibroblast-like. So they contribute to some of this inflammation and joint dysfunction. And then later in the process, another thing that can occur at the joint is this pannus formation, or kind of sclerotic formation of the joint. These are some of the diagnostic criteria for rheumatoid arthritis. As you can see, these are consistent with some of the things that I've already mentioned that are key to this disease. So increasing numbers of joints involved, some of these blood markers or autoantibodies. The duration of symptoms is also important, so chronicity. So I want you to revisit your chart that you're making on your sheet, and if you can, take a couple minutes based on all of that information. I know I'm going quite quickly, but this is not meant to be a super in-depth discussion of the pathology, just to give you an idea of how these things contribute to what we might see in a musculoskeletal setting. So think through what you might see within your subjective findings or history with your patients. And then because of those pathologies that we mentioned, what are some of the objective things that you may see within a physical therapy evaluation at these different joints? So which joints are affected? What would you expect to see in an inflamed joint? Would there be pain present? Which motions would cause pain? How would your muscle testing look? So think through some of that as you're starting to plug in the pathology to what you know about these diseases. Next, I want to discuss briefly osteoarthritis and some of the key signs and symptoms of this dysfunction or this disease process. Demographics for these individuals, as I mentioned, increasing age is the most common or the single biggest risk factor for osteoarthritis. So as age increases, we think that this is a lot more common, this type of dysfunction. Gender, overall, females will experience more osteoarthritis. However, in populations who have osteoarthritis that are less than 50 years old, it's more commonly experienced in males over females. So that's what those statistics show at the top of the slide. Risk factors for osteoarthritis, some of them are modifiable, some of them are not. So genetics has a role in this disease process. Some of the risk factors that maybe are more modifiable are obesity, joint trauma can contribute to this pathology. So we know prior history of joint trauma increases the risk of osteoarthritis. Usually this is, again, an insidious onset or a gradual progressive disease. It doesn't happen immediately after trauma. The trauma can predispose to later development of OA. This is usually present, as I mentioned prior, in a single joint or oligoarticular few joints, not commonly present in multiple joints. Hip and knee are most common. Also could be present in the shoulder. First MCP, first MTP are affected or could be affected in some individuals. And then, as I mentioned prior, although it's not on here, PIPs and DIPs preferentially if it is in the hands versus MCPs, more of an RA presentation. Joint deformities could be present later on. Key differentiator here is that we don't expect systemic issues. So we don't necessarily, or we really don't expect fatigue or any cardiopulmonary complications with OA. It is localized to joints. Treatments, first-line treatments for osteoarthritis, medication-wise, we're thinking choosing low-risk medications to control pain and maybe a little bit of the inflammation. So NSAIDs and Tylenol, commonly prescribed. Injections also could help with pain control for some individuals with more severe disease, so corticosteroid injections. Hyaluronic acid is sometimes mentioned, though there's some conflicting evidence on its efficacy. Physical therapy treatments that we're going to utilize for these patients, you're probably very familiar with. So usually we want to increase range of motion, increase strength around the joint. Modalities could be used for pain control and possible prescription assisted devices. Some of the pathology around the joint in osteoarthritis. So these next two slides, they're pictures that I pulled from a couple different articles that go into quite a bit of depth on the pathology and pathophysiology. If you want to know more, I would recommend that you reference those articles and give those a read. I'm going to talk just generally about some of these processes. So within osteoarthritis, you could either have primary or secondary osteoarthritis. Primary refers to the idea that this disease process is idiopathic, so we don't know what causes it or what starts it. Secondary osteoarthritis is due to some sort of trauma or disease at the joint that kicks off this inflammatory and destructive process. So sometimes we have a trauma that we can link back to that says this is the cause of some of that early joint destruction. And specifically in osteoarthritis, we think the articular cartilage damage happens early within the disease process. Damage to this cartilage is going to kick off an inflammatory cascade, again, with the production of some of these pro-inflammatory cytokines and influx of pro-inflammatory cells, such as macrophages, neutrophils, that are then going to contribute to the cycle of dysfunction and destruction at the joint. So as these pro-inflammatory cells enter into the synovium and articular cartilage and some of these joint tissues, we think that they contribute to destruction of the articular cartilage. They contribute to chondrocyte death. As chondrocytes or cartilage cells die, this tips the balance in an adverse way. And what I mean by that is those chondrocytes are usually making collagen, making proteoglycans, contributing to some of the restore and repair of those tissues that promote healthy cell metabolism and turnover. As the chondrocytes die, what we get is this imbalance such that catabolism takes over and we don't have as much anabolic action or building up of those tissues. So the breakdown continues to accelerate. Another thing that's mentioned in this article is the contributing factor of damage associated molecular patterns. So some of the cell signaling that contributes to the inflammatory process. This is another figure, and I don't want you to be overwhelmed by this, but one thing I like about this figure and why I included it is it really shows some of the inflammatory cytokines that are present. So some of these interleukins, TNF, and others, and also the inflammatory cells and how they're affecting each component of this joint structure. So not only the different zones of that articular cartilage you can see are degraded on the right side versus the healthy joint structure and tissues on the left side of the figure, but then also how these different factors contribute to some of the degradation of the bone surfaces, and increase in these osteoclasts, which are tearing down cells, versus osteoblasts, which are building. So I kind of like this picture. This slide just is presenting some of those risk factors that I started to mention that contribute or could contribute to the onset of osteoarthritis. So some of them on the left are local or controllable risk factors. So could be an increase in weight, could be some of the imbalances, muscle imbalances or muscle weakness. Diet can contribute. And then some of the non-modifiable risk factors. So increase in age, you're not going to control getting older. Gender, genetics, ethnicity, those sorts of things. We know African Americans are preferentially more affected by this disease. This is just a highlight. I think this can't be said enough because I want you to keep this front of mind as you're thinking about the differences between these two dysfunctions. Systemic symptoms should not be present in osteoarthritis. However, in rheumatoid arthritis, that's something that we do expect to see. This is the reason I brought this in is this is one of our clinical prediction rules that we will utilize in orthopedic physical therapy commonly that highlights some of the clinical signs and symptoms or cluster of findings that we may expect for an individual with hip osteoarthritis. So because of that joint space narrowing and some of those inflammatory processes, we would expect that an individual may have pain with squatting. They may have pain with compression at the joint or a positive scour test. And then we're expecting that some of the motions at the joint, and in particular within this cluster of findings, active flexion and active hip extension are likely pain-provoking for these individuals. We also will commonly see reduction in joint motions because of the decreased joint space. So characteristic in the findings of hip or the presentation of hip osteoarthritis is a decrease in internal rotation range of motion. So what I'd like you to do now is start to conceptualize and add to your list of some of the defining characteristics of osteoarthritis that you may see in your physical therapy subjective examination that we've discussed, and then what are some objective findings that you may see. And you can pull in or you can have in mind a specific joint of interest, for example, hip, that I just discussed. This slide is just a quick comparison of some of the pathophysiology going on at each of these joints. This comes from an article that is theorizing or proposing the use of MSCs or mesenchymal stem cells, so an orthobiologic treatment for these different pathologies. As I mentioned earlier, some of these orthobiologics, stem cells, hyaluronic acid, are being used to treat these dysfunctions. However, our research is still pretty new in these areas and a little bit inconclusive as far as the efficacy. But the idea is that if we can reverse some of these pathological changes with some orthobiologic agents, that may be helpful for the disease cause, but too soon to say a definitive yes or no as far as those go. I want to bring this in because this was a quotation that I really liked from an article by Huang 2021, is hitting the highlight of some of the differences that we've discussed between osteoarthritis and rheumatoid arthritis. RA is a chronic systemic autoimmune disease. So systemic and autoimmune, very key, characterized by joint inflammation and bone erosion. So destruction at the joint and subsequent inflammation. Osteoarthritis is a degenerative joint disease that triggers the gradual loss of articular cartilage. So again, joint destruction focused on the articular cartilage component. However, systemic issues are not there. Here is just a slide to cue you to be filling in your differentiators so that you have that and you have a better understanding of that. So what are your findings for these different types of arthritis? One last imaging example. This is something that we are looking at maybe more clinically, since we don't have x-ray vision. And this is just an individual who has some joint deformities that are external. So which pathology do you suspect in this image? What do you see at these joints? You can see the arrows pointing to those deformities. And which do you think is more likely, RA or OA, and why? So in this particular picture, this is a representation of some of the nodules that could be present in osteoarthritis. These are referred to as Heberden and Bouchard's nodes, as I mentioned. Heberden is just the name for those nodules that are present at the DIPs versus Bouchard's at the PIPs, which you see. And you can see at the PIPs a medial and a lateral nodule, and then lateral at the DIP. Next couple of slides as we wrap up are meant to be resources. They're not meant to be all encompassing, but these are some of the things that we will start to think about as patients come in with these diagnoses, or we start to obtain or ascertain evidence to support each of these diagnoses. How will we help these patients within a physical therapy context and educate them on potential adjunct treatments, whether those are medication-based or outside the scope of our PT practice. So patient education for osteoarthritis will likely be focused on the importance of exercise, weight loss if appropriate, could focus on some of the options and first-line treatments as far as pharmacological treatments. For rheumatoid arthritis, it's key that we are working with, or this patient is working with, a rheumatologist to control the autoimmune component with medication. Some of our physical therapy treatments are going to be similar across these two conditions. So exercise is very important, and exercise is well supported for the treatment of each of these conditions. Specifically, I wanted to mention within rheumatoid arthritis that exercise, you may think loading around a joint could be harmful to that joint. That's not found to be true. That has not been found to be true. So exercise has been found to be safe for these individuals, and a combination of aerobic and strengthening exercises is prescribed and recommended with our best practice guidelines. One thing to mention in comparing or contrasting maybe some of the treatment choices for these conditions would be the use of modalities. So within the clinical practice guideline for treatment of hip osteoarthritis, Cibulco, I believe, is the first author on that, and you'll see that in my citations. The use of heat and ultrasound is suggested, and a recommendation of high quality evidence for those in the treatment of hip osteoarthritis for pain relief in the short term. So you're not going to change function in the long term, but to control pain, those can be helpful. Treatments for rheumatoid arthritis and some of the pain control that we might get from modalities could be heat, could be paraffin. One of the things that I didn't mention, but I meant to, is that often individuals with these two disorders will complain of stiffness in the morning, so morning stiffness. The differentiating factor usually that we think of with that morning stiffness is that in the presence of osteoarthritis, those individuals usually have a resolution of stiffness within the first 30 minutes to an hour upon waking. So stiffness that doesn't last longer than an hour is more indicative of osteoarthritis versus rheumatoid arthritis. Some of that stiffness caused by inflammation can persist greater than an hour. So in order to remedy or help control some of the symptoms of that inflammation, persisting inflammation, and maybe stiffness, heat is oftentimes recommended as palliative for that complaint in rheumatoid arthritis. Could take the form of a heat pack, could take the form of warm water baths, or potentially paraffin if they have access to that. This is just a comprehensive slide showing some of the evidence for these treatments that we have discussed, and this comes from the American College of Rheumatology guidelines, so the recently updated guidelines. Wanted to give you that as a resource. And then this is kind of a comprehensive table. I'm not going to go through all of that, but this starts to talk about and conceptualize these different treatments that we've discussed for osteoarthritis. These are my references, and thank you for joining me for this discussion of the differences between osteoarthritis and rheumatoid arthritis.